Hello, everyone. I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. Joining us today is Dr. Daniel Aronson. He is the medical director of the GBMC Pavilion Breast Imaging Center and attending radiologist, advanced radiology. Dr. Aronson, thank you so much for joining us today.
My pleasure, my pleasure.
This is one of the biggest groups we've had so far for Ask the Oncology Expert. No pressure. So we're just going to start. We have so many questions that people have pre-submitted, and we're going to really try and get to all of them. There's a lot of information, but we're going to start really sort of in general terms and just talk about breast imaging at GBMC and what some of the options are that are available to women.
Sure, sure. So basically, there are three types of breast imaging that we do. The gold standard is mammography. Mammography is readily available, relatively inexpensive, non-invasive, and has been shown in many studies for many years to significantly reduce the risk of dying from breast cancer, predominantly in women over the age of 40. So it's not perfect. I'm sure we'll get into that later. There are times when cancers are missed on a mammogram, particularly in women with dense breasts. But that leads into another modality, ultrasound, which we frequently use. And ultrasound is very helpful in sometimes characterizing things better that are seen on a mammogram. For instance, is something a cyst or is it solid? Things that are cystic tend to be benign. Sometimes we can see things on the ultrasound that can tell us more definitively if it's something is more likely benign or malignant, could potentially lead to a recommendation for a biopsy. Ultrasound is also helpful if somebody's feeling a lump in the breast and the mammogram may not conclusively show it. We can frequently see it on ultrasound. It's also helpful if you have a nipple discharge, for instance, a bloody or clear nipple discharge. Ultrasound could sometimes see things that the mammogram doesn't show. So it's very helpful. In women, there's some women where we actually start with ultrasound rather than a mammogram. If you're under 30, for instance, and you have a palpable lump, we'll usually start with ultrasound. The ultrasound may show a simple benign cyst and no other workup is necessary. Also, women who are pregnant or breastfeeding, who are having problems, or maybe they feel a lump, we will frequently start with ultrasound in that setting. Third imaging modality is MRI. MRI, many people are familiar with MRI. Maybe they've had it for a joint, say the hip or the spine or their knee or even the brain or spine. But an MRI is a little different. You know, it uses radio waves and a strong magnetic field and computers to create detailed images of the body and also the breast. In certain situations, we recommend women have annual screening MRI. For instance, if you have a genetic mutation with a susceptibility to have a hereditary breast cancer, or if you have a lifetime risk of, say, 20 to 25% of developing a breast cancer based on risk assessment tools, or if you've, for instance, if you've had radiation to your chest at a young age, say between the age of 10 and 30, for something like Hodgkin's disease. So MRI is very helpful for screening in those, but we also use MRI as an ancillary to help out during the workup for things that, for instance, if there's something equivocal or inconclusive seen on a mammogram or ultrasound, sometimes MRI can be helpful. MRI can also be helpful if you have something like a change in the appearance of your nipple, if the nipple becomes inverted, or if you have a nipple discharge. And the mammogram and ultrasound don't show anything, or they're normal. Sometimes MRI can detect an abnormality that can be helpful. It's also helpful for women who have been recently diagnosed with breast cancer to determine the extent of disease. Not in all patients, but in select patients, the surgeons usually will decide. MRI can be very helpful to help the surgeon plan the surgical approach. As an example, if there's something close to the chest wall, it might be helpful to the surgeon to know if there's involvement of the chest wall. Sometimes there are patients who have breast cancer diagnosed by abnormal lymph node in the armpit, but the mammogram and ultrasound don't show any other abnormality. MRI can frequently be helpful in that setting. So MRI is out there. We use it very often, but usually more as a complementary or ancillary modality, except in the cases I've indicated before where it's helpful for annual screening.
So, Dr. Aronson, as I hear you describe these three categories, I mean, one question that I have is why bother doing the mammogram? Why not just give everyone an ultrasound?
All right, well, it's a very good common question. No imaging test is perfect, and the MRI is not perfect. It's very, very sensitive. It can detect a lot of abnormalities, but it lacks in specificity. In other words, there are many normal, benign things that can enhance on an MRI. And it's really not a good idea for women to have regular MRIs who are at average risk for breast cancer because it can lead to a lot of additional things. It can lead to additional tests, it can lead to additional biopsies that can cause a lot of anxiety. Because of these false positives, what we call them, things that show up or enhance on an MRI but are not cancerous, it's really not recommended for routine screening in women who are average risk. The other issue is there are cancers that are seen on a mammogram that do not show up on an MRI. So that's a possibility. So it's really recommended that for screening purposes, mammography is the gold standard. MRI very, very helpful in select situations, but because of the false positives and the things that can show up or enhance that are benign, it's not recommended to replace mammography.
So when you say MRIs, are you including ultrasound in that too?
No, that's
okay. So
different.
I guess I'm wondering the difference between the mammography and the ultrasound. I got the sense that the ultrasound is your second step when the mammogram shows something, and then I was wondering why not just do an ultrasound in the beginning?
Well, the ultrasound is again not perfect.
Okay.
It can pick up a lot of things, but there are many, many types of breast cancers that are seen on the mammogram that are not seen on the ultrasound. The mammogram can detect calcifications in the breast, which although are usually benign, can sometimes be associated with breast cancer. Almost always those will not be seen on an ultrasound. And also on the mammogram, there can be subtle changes in the distortion of the breast or the architecture of the breast that would not be appreciated necessarily on ultrasound. Now, 3D mammography has really kind of changed the landscape in the last 10 or so years, especially for dense breast tissue. With 3D mammogram it takes multiple 2D images and it builds a 3D image of the breast. And it's really helpful for detecting abnormalities that can be hidden by the dense breast tissue.
Okay, now the big question, and we talked about this a little bit before our official conversation, but women have been told over the years many different times or given different pieces of advice about when to first get a mammogram. And the ages keep changing a little bit. Where are we now? When should women start getting a mammogram? And I guess that would change depending on family history too.
Right. So an average risk patient, the recommendations of the American College of Radiology and the American Cancer Society and the Society of Breast Imaging are all pretty much the same. Start at age 40 and have an annual mammogram. Now, what you said is correct. That could be changed if you have an increased risk due to family history or due to a genetic mutation. We could potentially start screening sooner. And it really should be annually starting at age 40 and continuing while you're in good health. The American Cancer Society says, if you feel like you've got another 10 years to live, continue with your mammogram. A lot of women, when they reach their 70s and 80s, ask, well, should I keep coming? And so it's variable, but it really depends on the individual patient and their overall health. But if you're in good health, you should just continue having it every year. But age 40 is pretty much agreed upon as the starting point for an average risk patient.
So you don't cap that off at any age?
No, sometimes women, we read screening mammograms of women in their 90s. If they're in good health and they're able to come to the center and I think that's fine.
Let's talk about 2020 and the pandemic. I would imagine that nobody was getting a mammogram during 2020, and then everyone rushed to get a mammogram during 2021. Is that what you saw?
Yes, there definitely was a big drop off. Especially when there was a lockdown and only emergent procedures were being done. So yes, we did have a large drop off, but we certainly have been catching up and doing a lot of mammograms recently. So that's good. But yes, there was a gap in there.
So, and a lot of people have asked while we're talking about the pandemic, with the vaccinations, how could that affect the screening process? How do women time that out? What's the recommendation there? And now we're talking about getting boosters and flu shots and any other vaccine that might come along, shingles, you name it.
Right, right. So yeah, very common question. So the lymph nodes are part of your immune system, and they're throughout your body, but they're clustered in certain areas in the armpit, which we call the axilla, for instance, in your neck, in your groin. These are areas where you have groups of lymph nodes. When you receive a vaccine, the lymph node is activated and it's producing white blood cells, which are going to help fight off the infection. When that happens, a lymph node can swell or enlarge. Sometimes it can be painful. Sometimes you can actually feel it. Now, the significance, and that's all part of a normal immune response. The issue is that when we do a mammogram, we routinely image the armpit area. And if an enlarged lymph node shows up on a mammogram, as a screening mammogram, that could result in a patient being called back for additional studies, typical ultrasound. That could result in additional workup, additional follow-up, anxiety, confusion, inconvenience. And it really is just because the lymph node is enlarged from the vaccine. So what I would recommend is the following. Have your mammogram before your first shot. If you have a mammogram, if you have a vaccine, either have the mammogram before the vaccine or wait 6 weeks after your second shot, because this swelling of the lymph nodes is temporary. It will eventually resolve. So if you wait till 6 weeks after your second shot, then it would give a chance for the lymph node to decrease in size, and you can have your mammogram then. Now, let me quickly add that this applies to women who are having screening mammograms, that is, are asymptomatic. If you're having an issue, if you're having a problem, you feel a lump, you've got a new problem, then you should come in and get your breast imaging right away. You shouldn't delay it. We can make the assessment and determination based on that. So that guideline for before your first or 6 weeks after your second shot applies to screening mammograms, women who are asymptomatic.
So if you have symptoms of anything, come in and get checked, vaccine or no vaccine.
Exactly, yeah. I mean, if we can assess at that time, and if the lymph nodes are enlarged, we can usually determine that. But I would not delay the imaging if you're having a current problem.
Okay, and Dr. Aronson, we have so many questions here, and I want to make sure that we touch on them for the people who are watching and want to hear your answers. So I'm kind of click down the line here a little bit. Someone wants to know, what do the tests of these imaging processes tell us? And then if there's an issue, where do women go? What happens next?
So, right. So if you have a breast imaging study, there's really, several different potential outcomes. We could, if someone comes in, for instance, where they feel a lump in the breast, very often it turns out to be something benign, such as a cyst or just normal dense breast tissue. So one potential outcome is everything looks normal. We don't need to do anything else. Come back in a year if we can make that determination based on the imaging. Another potential outcome is we see something that we classify as most likely or probably benign. There's many, many things that could cause these benign entities on breast imaging. And those we would sometimes recommend a short-term follow-up, commonly say come back in 6 months. We usually reserve those for things where we're about 98% chance, 98% chance that it's benign. Another possibility is we see something that requires a biopsy on either a mammogram or an ultrasound. So that gets you into a different pathway, and we would have a discussion with the patient about that at that time about the biopsy recommendation and what that entails and how to set that up and what we do, the type of biopsy we would do, where we would do it. So those are kind of the potential outcomes from having a breast imaging study.
We had a lot of questions about, and I guess that would be called a needle biopsy. Is that correct? So we had a
That's
lot of
correct.
questions about the different types of needle biopsies. Are the biopsies painful, and how accurate are the results usually?
Well, we do 3 different types of needle biopsies, depending on the modality. So the most common we do is an ultrasound guided biopsy. These are things that are seen on ultrasound. For instance, somebody has a palpable lump in the breast. We can see a lump or a mass in the breast, and we very often biopsy those with ultrasound guidance. Those are frequently benign, but sometimes it can be indeterminate or equivocal. So we could do a biopsy with ultrasound guidance. The way it works is the breast is scanned just like when you have a regular ultrasound. A local anesthetic is administered, a needle placed in the breast using the ultrasound machine as a guide, and after everything is anesthetized, of course. And then we can retrieve tissue from the area, send it to the lab. It usually takes about 4 days or so to get results from the lab. So that's a very common type of biopsy we do. I should quickly add that the majority of biopsies that we do are benign, that is not cancerous, about 80% of the time. Another type of needle biopsy we do is called a stereotactic biopsy. Those are reserved for things we see on the mammogram, but not seen on the ultrasound. Examples of that might be calcifications in the breast or subtle areas of distortion of the architecture in the breast, only appreciated on a mammogram, for instance, a 3D mammogram. And in that situation, we use the mammogram machine as a guide rather than the ultrasound. Typically, a patient would be lying on their belly. When there's a hole in the table, we work underneath. That's takes a little longer. It's a little more uncomfortable because instead of lying on your back, like you would for an ultrasound biopsy, you're lying on your belly. But those are reserved for things that are seen on the mammogram and not seen on the ultrasound. The third type of needle biopsy, which we do less frequently than the other two, is an MRI-guided biopsy. And those are reserved for things that are only seen on MRI. They're not seen on the mammogram. They're occult on the ultrasound and mammogram. And as I mentioned before, you have lots of things that can enhance on an MRI, not seen on the mammogram. So we could use the MRI as a guide to do a needle biopsy as well. The general concept and procedure is the same as far as administering local anesthetic, placement of the needle using the imaging guidance. The difference is which modality you use, whether it's ultrasound, mammography, that's the stereotactic biopsy, or MRI. They're extremely accurate, almost 100%. It's uncommon that we don't get a definitive answer from one of these biopsies. The answer about the pain is, I will tell you, having done many of these, that the vast majority of patients, after it's done, say it wasn't as bad as I thought it was going to be. So that's good. We administer a generous dose of anesthetic. We can tailor it if someone, everyone's a little different. If someone's, having some tenderness, we can add anesthesia during the procedure, even after it's started, to make them more comfortable. But most of the time, it's painless except for the initial needle stick with the local anesthetic, and it's extremely accurate. Serious complications are extremely uncommon, way less than 1%, and that includes infection, significant bleeding, things of that nature. Most of the time, there's maybe some minor bruising, but that's pretty much the extent of it.
For the some 80% of the women who have the biopsies and get a benign result, does their follow-up change now? Does their mammography schedule change? Do you want to see them more frequently?
It depends on the actual result. There's many, many different types of benign results. If we see, for example, something that's very common is called a fibroadenoma. It's a very common solid tumor in the breast, predominantly in young women. We see it often in women in their 20s, 30s, 40s, and also in teenagers. If you biopsy that and it comes back unequivocally a benign fibroadenoma, no additional workup is necessary. There are instances where we might ask you to come back in 6 months If we feel like it's concordant, the benign result is concordant with the imaging studies, we might have you come back in 6 months just to look again. An example of that would be if we're biopsying some calcifications and we get a good representative sample, maybe there's some residual calcifications. We just want to make sure that everything stays stable. So sometimes we'll do a short-term follow-up. 6 months would be a typical short-term interval, even after a benign biopsy.
Okay, a couple questions have just come in. Should women with the BRCA1 gene get an MRI with contrast at age 25 or 30?
Well, definitely with contrast. When we do MRIs looking for breast cancer, we always give contrast. There are certain MRIs, breast MRIs, that are done without contrast, and that's usually when we're looking to evaluate silicone breast implants to look for implant rupture. I would hesitate to give a definite age. I think your risk assessment should be tailored individually. Meet with one of the surgeons or someone else in the breast center to discuss your individual risk. But very often they'll start earlier than the routine imaging and have annual screening MRI. What we like to do also is to stagger it. So if you have a genetic mutation and you are having MRI annually, very often we'll recommend doing it at 6-month intervals from the mammogram. So as an example, have your mammogram in January, have your MRI in June. So every 6 months, you're having one or the other. So very often it would be earlier than the typical screening age, but the actual age would be varied depending on your individual risk and your family history and the type of genetic mutation.
Okay. Is ultrasound an option for someone with intense cystic breast pain that cannot tolerate the mammogram? Dr. Aronson? I think we've lost a little bit of our communication. Hopefully we can get him back. Can you hear me, Dr. Aronson? All right, we've had a little bit of drop off, but we are speaking with Dr. Daniel Aronson. He is the medical director of GBMC's Breast Pavilion Imaging Center and attending radiologist in advanced radiology. And we're talking about screening for breast cancer, making sure that you have breast healthy, that you're checking your breasts yearly and how to do that. Are you back, Dr. Aronson?
Yes.
All right, awesome. Did you hear the question about the ultrasound?
Yeah, right. So there are some patients who, for one reason or other, say they don't want to have a mammogram. Either it's too painful or they're concerned about, radiation, even though the radiation is extremely small. So in that situation, yes, a screening ultrasound could be done. It's not as good as a screening mammogram, but it's better than nothing. You can do screening ultrasounds every year, but I would highly recommend and reiterate that the gold standard is mammography.
This is a very specific question. I'm not even sure what all these terms mean exactly, but how often are MRIs graded as BI-RADS 5 and biopsy results come back benign? Does that make sense to you?
Yes. So the BI-RADS refers to categorizing findings we've seen on breast imaging. And after every study, we give it a designation. BI-RADS 1, for instance, is normal study, completely negative. BI-RADS 2 is something that we feel is benign, doesn't require any additional workup. BI-RADS 3 is something that is probably benign. Those frequently result in short-term interval follow-up, say 6-month follow-up. BI-RADS 4 is something that looks suspicious. Biopsy is recommended, but that's a very, very large spectrum of things that could be, benign or malignant. For instance, even something that looks benign like a fibroadenoma would get it designated as a BI-RADS 4 because a biopsy was recommended. So BI-RADS 5 is reserved for a small percentage of cases where the radiologist feels that there is a very highly significant percentage chance that this is going to be malignant, more than 90% chance. So if you have a BI-RADS 5 finding and your biopsy is benign, it's extremely incumbent on the radiologist to coordinate and the imaging with the pathologist, with the pathology and make sure that the findings are concordant, that the biopsy pathology results are concordant with the imaging. Because if something looks very suspicious on the imaging, but the biopsy comes back benign, there's always a concern that there was a sampling error, something was missed. Frequently, those patients will end up seeing a breast surgeon, maybe having an excisional biopsy. So typically, it's tough to generalize, but generally speaking, if something is a BI-RADS 5 and the biopsy comes back benign, that's kind of a red flag. We need to kind of stay on top of that and make sure that something wasn't missed.
Okay. A couple more questions here with the time we have left. What should a patient with recurring calcification of milk ducts do to ensure they're getting accurate readings on mammograms, especially those with a family history of breast cancer?
So calcifications are extremely common. Most women, once age again in 40s and 50s, they're going to have some calcifications in their breast. Vast majority of calcifications are due to benign causes. Fibrocystic changes and other benign causes. And we can very often look at a mammogram, see a calcification, and say, it's definitely benign. Sometimes you can look at a group of calcifications on the breast and say, very, very highly suggestive of breast cancer. And then there's a very large spectrum in between, where things are kind of indeterminate. And sometimes those end up being biopsies, sometimes they end up being followed in 6 months. But specifically the question about relying on getting an accurate reading, I'm not exactly sure what you mean. I mean, one thing you should definitely do is make sure you're going to a certified imaging center by the American College of Radiology that's designated as a center of excellence, where we have audits and quality assurance, and it has to be renewed every 4 years. And of course, make sure your study is being interpreted by a board-certified radiologist who specializes in breast imaging. So those are ways you can assure you're getting an accurate reading. But just because you have calcifications doesn't mean it's necessarily anything bad. Most calcifications are benign.
Finally, and sort of wrapping things up and looking ahead to the future, can you talk about where technology is taking us or advancements in screening that you hope to see soon?
Well, there are a few things. I mentioned that mammography, ultrasound, and MRI are the mainstay right now. But there are certain types of breast imaging that are being researched and studied in the literature. Something, for instance, called molecular breast imaging, which is a type of nuclear medicine study, which images metabolically active breast tissue. Many patients are familiar with nuclear medicine. Maybe they know someone, or they've had a PET scan or a bone scan. So it looks at tissue in the breast that's metabolically active. And there is some possibility that this could be a supplemental screening for patients who can't tolerate MRI, reduce those false positives. Not everyone can have an MRI. If you've had a pacemaker, if you have a pacemaker, you have a cochlear implant, extreme claustrophobia. So it's possible that could have a role in supplemental screening.
And finally, Dr. Aronson, it's not just you standing alone, although you do a great job yourself, but it's a whole team at GBMC. And so when a woman comes to you and has to take a next step for whatever reason, you meet with a whole group of people to talk about that particular case, don't you? Oh, I think we have lost him, but actually our time is up anyway, so he's a busy man. Hopefully he get right back to it. And we appreciate all the information that Dr. Daniel Aronson has given us today. Oh, there you are, so we can say a proper goodbye. Thank you so much for joining us today. I was just commenting on the team approach at GBMC and how you are one important piece of the machine, but you have a whole team of people working on each individual case.
That's correct. I mean, there's the breast surgeons, there's the medical oncologists, the radiation oncologists, the nurses, the nurse navigators, the geneticists. So yeah, it's all done as a team approach. Very often patients are discussed in a multidisciplinary tumor board conference to work out the best plan for that patient.
All right, Dr. Aronson, be well. Thank you so much for joining us today, and thanks to everyone who joined us on Ask the Oncology Expert. We'll see you next time.
My pleasure. Thank you.